Hello, everyone. Hello, everyone. Can you hear me? Okay, wonderful. Now that I have your attention, welcome, everyone. I'm Dr. Shanti Johnson, Dean School of Public Health at the University of Alberta. It is such a pleasure to welcome you to the Douglas R. Wilson Lecture for 2022. Before we begin, I would like to respectfully acknowledge that the University of Alberta is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others, whose histories, languages, and cultures continue to influence our vibrant community. This year's gathering feels particularly special to all of us here in the School of Public Health, as this event, like so many others, had to be suspended for the past couple of years due to the pandemic. I would like to thank everyone in the school who has contributed to organizing this hybrid event. We have many of you who are joining us here, but we have several who are joining us online, including our keynote speaker today. We are delighted to welcome our guests both on campus here, a wide cross-section of our community, from our amazing students who've just started our program to our longstanding alumni who are here as well. And so very delighted to welcome you. It is wonderful to be here together again with you, whether you're here in the room or joining us virtually. To honor Dr. Doug Wilson, Dr. Doug Wilson's profound impact in the field of public health. The pandemic has exposed long-standing drivers of health inequities and has shone light on how critical equitable health governance is to solving the world's most complex public health challenges. Here in the School of Public Health, and indeed across the 6 faculties that have come together under the umbrella of the College of Health Sciences, we have all borne witness to how the pandemic disproportionately affected a broad range of vulnerable populations, both here in Edmonton and around the world. With the pandemic as our backdrop, it is a great privilege to host our speaker, Dr. Soumya Swaminathan, Chief Scientist at the World Health Organization. Dr. Swaminathan will be speaking about the urgent need for better health governance, particularly in light of the inequities exposed through the pandemic. And now, before Dr. Swaminathan joins us, please help me welcome Elderbert Auger, an insightful advisor and key member of the School of Public Health community. We are honored to have him here with us to ground us in gathering. And I will offer him a tobacco bundle. And this bundle was put together by one of our former students, Regan Barthal, with a group of students joining together. And she's now serving as the Director of Research at Métis Nation. So amazing school students. And with that, I offer this tobacco bundle.
Thank you so much, Santi, for the kind words and kind introduction. My name is Bert Auger. Napio Kanihio Mostit, Whitefish Lake Oche. Man that walks the native way. I just got my native name a few weeks ago and so proud. I've been waiting for over 62 years to get it. I think you have to earn your name in our culture. But I have 20 other nicknames that work too, like Trapper and Ugly Guy, whatever. It'll take a while for me to go through them, but so I won't do that. Such an honor to be here, always an honor, and always I'm full of gratitude, right? So when someone offers you tobacco, you come to speak, and the tobacco is the contract. It's an ancient tradition, right? To offer gifts and tobacco to Indigenous people if you want them to come and speak or talk. This one question came up the other day that was so interesting to me. And before I do that, before I tell you the story, I wanted to open with a blessing because that's our traditional way. And I don't want to forget the words I had memorized for such a long time. So our language sounds like this, and I'll tell you a little bit of that history in a second. Nuftawinan, if we can just all rise. Nuftawinan, miugisagawa mo naskumnan, kakiyaw da kapi dito. Mios no kapi kakiyaw snamatuya kakiyaw speaks kwatuya mios. Kakiyaw ta Santi Stephanie Susan Kanagatim Toman Naskumaniboch. Thank you, Creator, for bringing us here. We ask to say some blessings to the people in Ukraine and the kids that continue to be found in residential school graveyards. We thank you for bringing everybody here, and we bless this event and the people around it. And we thank you for the relationships that continue to be built with the U of A and people in other community and around the world. Hi. So I just wanted to talk about that a little bit. We were at a couple of events recently, and people ask, who are we and where you come from and how long you've been here? I got into a bit of an argument with the Pakistani, nothing against Pakistani people, Pakistani taxi driver. He said, you know, sir, you guys haven't been here very long. You're lucky you've been here 500 years. I said, you have a lot to learn, sir. Just recently, we believe we've been here since time immemorial. And this is a new story for Stephanie, because I always quote numbers about this. This guy comes up to me the other day and he says, you know, Elder OJ, we just found more evidence of the indigenous people being here for 23,000 years. So again, I do a quick calculation on my phone. It's 766 years. 766 generations, 766 generations we've been here on this land. And as I sat and talked to Dr. Doug Wilson and Alexis this morning, we were talking about our participation in mainstream society as indigenous people. And we had been very scared for a long time of teachers, RCMP, lawyers, priests, and all kinds of people that did all kinds of mean things to us, right? But we always said we will not give up, we will persevere. We'll continue to do what we've always done for thousands of years, and everything will be okay. And you'll run into people like Stephanie and Dr. Douglas Wilson that become allies with your people. So he told me stories of when they used to teach in down south with the Blood Tribe. I was part of an outreach program myself with Graham McEwen College, being only the second graduate from the Whitefish Lake First Nation since time immemorial from a university or a college. The first one was a lawyer. But we have decided that education will become our new buffalo. We decided that education and partner with educators to educate our people and bring us up to speed. We've only been doing this for 30 years, right? Only about 30 years. We have astronauts, doctors, rock and rollers. We have, I think, about 12 professors in the U of A that are indigenous. So we decided it's time to pull up our bootstraps and find people that will ally with us. And Santi, I'm so happy and full of gratitude that you allowed me to be here and work with you in the School of Public Health and their committees. What an honor that is to me. And my Mushum always said, Mushum is my grandfather. My Mushum said to me, he said, in order to build relationships with people, you yourself have to be kind. I said, no, I just want to fight with them. No, I'm kidding. No, I said, you yourself have to be kind. You have to have everything with good intent and say things in a good way. And you have to walk softly on this planet. And you have to share some of our histories, whether it be health, sustainable living, protecting the planet, advocating for the land, because we're people of the land, from the land. And so are you. And some don't know it, right? Some say, the land sustains you and sustains all of us. We have to protect it because that creates healthy living. right? It creates health, good health. So I think I think it's Stephanie or Santi were saying, oh no, it was someone else. Anyways, they were saying, you know, potato chips and Coke doesn't cut it. And in our communities, we love it, but we have to teach our kids that you have to go back to eating moose meat and wild rice and wild onions. We have so much that in Whitefish Lake that can sustain us in a good way and has for thousands of years, right? So the earth was our oyster, basically, right? So anything you wanted, the land gave to you and gave you health and medicines and everything you needed. We want to share that with you. We want to share those teachings with you. And I have I learn under 10 different elders throughout the province and throughout Canada that always say, Bert, say things in a good way. Be kind to each other, and then we'll solve all the world's problems. Sometimes when I'm giving this speech or talking about it, I thought, I have the same purpose as Miss Universe. Peace on earth, right? All live in peace together, right? Yeah, peace on earth. So it's getting along and sharing our stories. But I have to commend the U of A on their efforts to indigenize programs. I know it's a slow start. I know it's a small step, but it's a small step in the right direction. And I was telling this elder, that's kind of like moving a mountain, right? And he says, yeah. I said, I was thinking about it, and it came to me. I thought, so if we move a pebble at the foot of the mountain, we've actually moved a mountain, right? Because the mountain's part of it. So that's what we're doing. That's what Santi, Stephanie, Dr. Douglas Wilson, and all the people and Susan Chatwit from Northwest Territories that helped me in this journey. And I learned so much from them and you, and from the students up there. Hi, students, I love you. They were online. It was nice to see them in person. Thank you so much. I hope it goes well for you today. The meal was wonderful. Hi.
Thank you, Elder Oje, for your prayer, blessings, and teachings, and the support that you continue to provide the School of Public Health on our reconciliation journey. Wonderful. As many of you may know, Dr. Douglas R. Wilson, who is here with us today, was the Dean of the University of Alberta School of Faculty of Medicine from 1984 to 1994. While he began his career as a nephrologist in Toronto, Dr. Wilson's passion for public health eventually led him to a career shift towards health promotion. He's such a strong believer in the upstream intervention that provides solutions for complex health challenges. In fact, he was the chair of the poorest task force that recommended the establishment of Canada's first freestanding faculty dedicated to public health, our School of Public Health, right here at the University of Alberta. We have been fortunate to benefit from his years of experience, his wisdom, his generosity in spirit, and in sharing his knowledge and insights. We are very grateful. It is thanks to Dr. Wilson that this lecture series is able to play host to some of the most leading experts on public health. Since 2015, we have been honored to welcome a diverse set of speakers from very different areas of expertise, complex public health and societal challenges, and this year is no exception. And now, here's Dr. Wilson to share a few words and let us know of a very special announcement. Welcome, Dr. Wilson.
Thanks very much, Shanti. It's a great pleasure for me to be here today and see so many old friends and meet some new friends. And I'd like to express my thanks to Shanti and her colleagues for organizing this event. It's a big task to get it all together in person and online, and so I certainly wish to express my thanks for that. And thanks to all of you for participating, being here in person or online. And I think we are in for a treat with our guest speaker, Dr. Soumya Swaminathan, and her topic towards a healthier and more equitable future for all is something which has been strongly identified with the School of Public Health in a number of our initiatives, and over at the Royal Alec and around the province. There have been faculty and students working hard over the years to try to address some of the health inequities that exist in our community. So we're looking forward to those remarks, which we'll hear in a few minutes. The last thing that I want to do is something that feels very special to my wife and I. We'd like to recognize this event by launching a new graduate student award in the Faculty of Public Health, an award which will recognize a graduate student in health equity and mental health, and provide support for them during their time in the university. And we will be giving the award to students who are from underserved communities, including those who have experienced inequities themselves, and in an effort to make the award as real as possible and have as much impact as possible. So we're excited to do that, and I'll leave you with that today. Thank you very much.
Thank you very much, Dr. Wilson. I know these awards and scholarships make a world of a difference in the lives of our students who are our future public health leaders. It makes a difference in their everyday life. And now to our keynote speaker, Dr. Swaminathan is joining us virtually from Geneva, Switzerland, which is 8 hours ahead of us. So it's quite late in the evening for her, where she became the World Health Organization's very first chief scientist in 2019. This new role was designated to ensure that WHO is at the cutting edge of science and working to bring new knowledge out of the labs and into the global community that is in most need. For more than 30 years of clinical and research experiences, Dr. Swaminathan is a pediatrician and a globally recognized researcher in tuberculosis and HIV. She received her education and training from her home country, my home country, India, as well as in the UK and United States. She is elected a foreign fellow in the United States National Academy of Medicine and is a fellow of all 3 science academias in India. Here in the School of Public Health, we proudly share that Dr. Swaminathan's mission to translate research into policies that have meaningful impact on the health of all global communities. Please join me in welcoming Dr. Soumya Swaminathan for a lecture on towards a healthier and more equitable future for all.
Thank you very much, Professor Shanti Johnson. Can you hear me all right?
Yes, we can.
Okay, thanks very much for confirming that. And thank you so much for this wonderful opportunity to share a few thoughts with you. And I really appreciated the remarks that were made earlier by Elder Auger and also by Douglas Wilson. And such an honor, sir, to give this talk today that's been named after you. What I will try to do today is to perhaps provide some glimpses from the vantage point that I've had here at the WHO over the past few years, particularly during the pandemic, sort of observing what was going on around the world, and hopefully then address this issue of what should we be doing today in order to ensure that we have a healthier and very importantly, a more equitable future for everyone. And I know that that is very much aligned with your vision as well. So if we can have the slides up, then I could start taking us through the presentation. And essentially, I wanted to both look at the health challenges that faced us already pre-pandemic and then post-pandemic, and what might be the best ways of addressing them, and some concrete examples of initiatives that we have undertaken.
You should be able to see them.
I was seeing them some time ago, but they've disappeared now. I don't see them, so it will be okay. I see them in a small box at the bottom, so maybe I need to change. Okay, I think that should be fine. I can see them now. Can we go to the next slide, please? So this, you may be familiar with this. It's from the Global Burden of Disease studies. As you know, the IHME in Seattle does these analysis periodically. And essentially, I just wanted to show this to basically highlight the fact that there is a shift, a demographic shift in the burden of disease across the world. And obviously this also varies by country, but essentially we're moving from a world which was the MDG era, perhaps in the 1990s and early 2000s, where maternal and child health conditions, undernutrition, were the major causes of death and disability, to an era today where chronic diseases that include things like cardiovascular disease and stroke, but also musculoskeletal disorders, depression, mental health, are the major reasons for disability. In the next slide, we will see again a similar trend in the risk factors. And again, you'll see on the left-hand side in 1990, we had things like the undernutrition problem, but also had prematurity and unsafe water sanitation and so on. And while some of those are still problems in some parts of the world, what we see today is that obesity, high blood sugar, high blood pressure, and air pollution, both ambient air pollution and indoor household air pollution, are big factors. But we still see low birth weight and prematurity as important causes, particularly of childhood mortality. So I think these type of studies are useful, but of course these also need to be done in a more granular fashion, at the national and probably at the provincial and state levels as well, to give policymakers a handle on what sort of burden of disease they have. But unfortunately, we don't have good data from many countries, and we saw during the pandemic that we could not even get data on deaths of any cause, let alone COVID deaths, from many countries. And this is why sometimes you have to resort to modeling, which has its own drawbacks. Next slide, please. One of the major impacts of the COVID pandemic, of course, was on other diseases. And I picked TB here as an example because it was the leading killer, infectious disease killer prior to the COVID pandemic, and will probably continue to be the leading killer once the deaths in the pandemic are on their way down. And you can see here the targets that we had for 2025 on reducing incidence, reducing deaths, and reducing catastrophic expenditures that people are unfortunately undergoing because of they're shopping around for TB diagnosis and treatment. And you can see that now we're at the end of 2022, we're still very far away from achieving any of those. And in fact, the TB incidence went up during the pandemic because of, many programs were not able to provide services and diagnostic services and so on. There are also other targets you can see at the bottom of the slide. Next slide. And so TB, I think, is something that, unfortunately, it's a disease of poverty. And so it doesn't get the kind of investment and attention, perhaps, the diseases which affect the developed countries get. And if you look at some of the funding targets, we are very far short of the $13 billion that are needed annually to just spend on programs, to diagnose and manage people, treat them. And about a $2 billion very modest investment in TB research and development that includes everything: diagnosis, diagnostics, treatments, vaccines. And we barely are at half of that. I think it was 900 million last year, as opposed to probably an investment of over $100 billion in COVID in just 2 years. And so when there is a need, when there is a global need and a demand, the money is there, for investment. But you can see that despite all of the advocacy and the awareness raising on TB and the increasing movements that civil society has undertaken similar to HIV, we haven't come close. Next slide. And I hope that changes. This is just to show a sort of visually where we are today, globally. We are seeing sort of a decline in both cases and deaths over the last few weeks. Though we see in different parts of the world, the different colors on this graph represent the different WHO regions. And you can see that some regions, still continue to have some peaks. And this is mainly because there are subvariants of Omicron. Since the beginning of this year, it's basically Omicron that's dominated. Globally, we have not had a major new variant, but we've had over 300 subvariants or sublineages of Omicron, and each of them has different combinations of mutations, and therefore they're able to become more transmissible and also more immune evasive. You can see the deaths. The black line is now at a sort of a plateau. It has dipped a little in the recent past, but still around 7,000 to 9,000 deaths per week. These are just deaths that are diagnosed to be COVID deaths. And as I mentioned earlier, in many countries, we don't have this capacity. So it's clearly an underestimate. And also the overall figures of cases and deaths are also underestimates. Next slide. The economic impact has been huge. You can see that, the different economic shocks we've had over the last century or so, that COVID actually was a much bigger shock to the system. And you can see what's happening around the world today in terms of inflation and in terms of, global GDP having really taken a massive hit. Unfortunately, however, again, there's an equity here. The poorer countries have taken a much bigger hit. If you see things like on the right-hand side of this graph, the support that was given to low-income households, this support was provided to a much greater extent in high-income countries. You saw the countries that were well off were really putting in a lot of money into the system to support businesses, to support poor families, to provide a lot of social support, which unfortunately the low-income countries could not prevent. So poverty is increased, and as a result of that, it has a cascading effect on nutrition and on many other things. Next slide. We've also seen impact on nutrition. Now, again, the circles here are probably too small for you to actually look at what they say, but they are all basically on the left-hand side, they are targets that were set, global targets that countries had agreed to in terms of improvements in maternal, infant, and young child nutrition. And on the other side, you see diet-related non-communicable disease targets, things like, reduction in salt intake, reduction in obesity, and so on. And we find that the orange part of these donuts actually tell you that the number of countries that are off track, or the percentage of countries. And so you can see that particularly on the non-communicable disease side, most countries are off track, meeting any of the targets. Whereas on the maternal and child, there are one or two targets like breastfeeding that are doing well. But again, in terms of childhood nutrition and anemia, most countries are not on track to achieve these targets. And as I mentioned, these have got worsened. The other link, of course, that's important here is to note that people who had underlying non-communicable diseases or chronic diseases did suffer from more severe effects of COVID and were the ones who ended up with severe illness and were hospitalized. Next slide. So there is a bidirectional link between communicable and non-communicable diseases sometimes, which is not always evident. Immunization, again, routine programs were impacted. We saw measles vaccination in particular drop down to their lowest levels. Southeast Asia was the worst affected region, but almost all regions were impacted. And now we have measles outbreaks in many countries. Unfortunately, there will be more of this unless countries make an effort to expand coverage and actually reach out to the children who had missed. So last year, 25 million children were either under-immunized or not immunized at all. And this number is significantly more than it was in 2019, where it was something like 19 million children. Next slide. And again, to show that COVID basically disrupted health services. But again, I don't show the data here, but if you look at low income, middle income, high income countries, it was low income countries where essential health services, whether they were surgeries or blood transfusions or maternal and child care or hypertension care, all of these were impacted, both at facility level and community level. And again, there was differences in the rate. And this was at the end of 2021. So it wasn't, at the peak in 2020. So there were still significant disruptions in many countries and across the different services. Next slide. And then here, of course, we look at on the figure on the left bottom corner, you can see the differences in primary vaccination coverage between the different groups of countries. The low-income countries, the coverage is still only around 25%, unfortunately, whereas the global average is now close to 70%. And again, even when we look at healthcare workers and people over 60 who were prioritized for vaccination, if you look at the low-income countries, these rates are still around 60 to 70%, whereas in many other regions, they're over 100%. And despite now the availability of vaccines, the low-income countries are still struggling to increase vaccination coverage rates for many reasons, which we can discuss later. And again, you see on the right-hand side a figure that shows excess mortality in red and COVID deaths in blue. And while COVID deaths, relatively speaking, were more compared to the excess deaths in high-income countries, which means that health systems were still able to cope. If you look at what happened in the developing world, the excess mortality was higher than COVID mortality. And this is probably due to the fact that people did not get access to services. Hospitals were full, they were overwhelmed, and people with other illnesses were turned away. And we've heard many stories of pregnant women, being turned away because they went to the wrong hospital or because they didn't have a COVID test and they actually died tragically during childbirth. The horizontal graph on the top actually shows you something different. It's inequities and access to diagnostics, which we don't often think about, but it's one of those things which is completely neglected in primary health care. And what it shows is that while the low-income countries are shown in dark purple as a percentage of global population, you can see that as far as access to diagnostics were concerned, it was practically the line is invisible, whereas the red constitutes the access to diagnostics as a percentage of the total available diagnostics globally. I know that at the beginning of the pandemic, for example, there were only 2 labs in India, in Africa, the African continent, that could do PCR, and for the whole continent. And of course, one had to work very hard. WHO worked with the partners on the ground to make sure that at least every country had at least one functioning PCR lab. Of course, now many countries have invested in that and also in genomic surveillance, to the extent that Southern Africa actually has probably the most advanced and strategic genomic surveillance capacity today, and has been the region of the world which has actually picked up 2 new variants, both Beta and Omicron were picked up in South Africa and Botswana. Next slide. So this is, I think, just to show you the data on what I was mentioning earlier, disparities in vaccination between the different WHO regions. And the next slide is healthcare worker coverage, which one would expect to be extremely high. But again, you see on the African side, it's still under 50, it's around 50%. And the next slide will show us the people over 60 who are, we know, the most vulnerable to severe disease. And here again, there are discrepancies between the different regions in coverage. Next slide, please. Now, slightly different aspect of equity, but this is equity around health research. And the WHO maintains something called the Global Observatory on Health R&D. You can look up the data on that, it's updated by the data that's provided by the top 10 or 12 global funders of research. I think the Canadian Institutes of Health Research is part of this, this database. And what we see is that less than 0.5% of overall global research funding is actually going to the low-income countries, and also a very small proportion is going towards research on the WHO list of neglected tropical diseases, whereas most of the research, you can see the red part of the pie chart here is non-communicable diseases. A lot of it, of course, goes to cancer research and other treatments for obesity and neurological illnesses and so on. And many of that, in the private sector, come out with treatments which are unaffordable and not accessible. Next slide. During COVID also, we saw some of these inequalities in the way that research funding was distributed. This is something that the GloPID-R group has been tracking. And you can see again that out of a total huge amount of funding, almost 5 billion at this point of time, over 12,000 research projects, that very little of it actually went into low-income countries. Most of the research was being done in high-income countries. And not only that, there was a lot of inefficiency and duplication of work, small clinical trials that didn't lead to results because of the lack of coordinated mechanism for coordinated funding of high priority projects. And we're discussing with GloPID-R how this could be improved before the next, sort of a global pandemic. Next. So coming to some of the, perhaps the learnings in terms of some things that might have gone better than expected. One thing, of course, we saw is that learning from past outbreaks and applying those lessons and strengthening systems. We could see in East Asia, for example, that had gone through the SARS outbreak, that they were better prepared, that they actually acted much earlier than the Western countries because they had seen SARS and they had an understanding of what to do. And the communities, the population actually accepted what the government was asking them to do. We also saw the power of science and technology in providing solutions. Record time, we had vaccines. We had not just a vaccine, but we had 300 vaccine development programs at one point of time. And we have dozens of vaccines that have received regulatory approval. We saw very good sharing of genomic sequencing data through GISAID. We have something like 13 million whole genome sequences and just over 6 million of Omicron alone. And everybody was sharing, starting with the Chinese, who shared the first 6 sequences on January the 11th. We saw a lot of innovations in the health system in terms of self-testing, self-monitoring, telemedicine and telehealth, the use of digital technologies, artificial intelligence, real-time data analytics, modeling. Groups came together. Most scientists gave up what they were doing to try and focus on COVID. And we've seen a huge output from that. Again, telling us that, when people work together around the world, when there's a common mission and there's some coordination, that, miracles can and do happen. Next slide. You've heard of COVAX. It was the partnership that was set up in order to do an end-to-end, so investments from the R&D all the way to procurement and delivery of vaccines for COVID. COVAX brought together WHO, Gavi, CEPI. CEPI is the Coalition for Epidemic Preparedness Innovation. Gavi is, of course, the Vaccine Alliance, and along with UNICEF. And we, from developing a research roadmap in February of 2020 to following through on developing target product profiles, developing core protocols for clinical trials. CEPI was funding vaccine development early stage. Gavi was doing advanced purchase agreements with companies that had got into vaccine development. Of course, at that time, we didn't know which vaccines would be successful. So most countries were betting on multiple vaccines. There was a lot of regulatory collaboration and harmonization, which has not been seen before. Again, a lesson for how we can do things better. There was very fast policy innovation process at the WHO. So SAGE which makes vaccine policy, was meeting frequently and updating their vaccine guidance. And we then set up the mRNA tech transfer program, which I'll say a little bit more about. But all of these innovations actually, including things like no-fault compensation for people who might suffer serious adverse events, were things that were done for the first time very rapidly. And this is what enabled, 2 billion doses of vaccines to actually flow through COVAX, mostly to low and middle income countries. Next slide. Of course, there were the downside was that in 2021, the delivery of vaccines to COVAX was very slow and very limited, because most high-income countries were hoarding doses to vaccinate their own populations. And countries like India, which are major vaccine producers, also had to vaccinate their own population. They prioritized that because of the terrible impact of the Delta wave there. And therefore, COVAX and many African countries were left with no choice but to wait, to late 2021 when vaccines started flowing again. And today, of course, there's no supply shortage. And this is one of the reasons why we thought of this technology transfer program to address this issue, not just in the short term, but in the longer term, and ensure that there's regional health security, you actually need local manufacturing capacity. And therefore, we set up a hub in South Africa. This was an open, sort of a competitive process. There were expressions of interest. There are 15 spokes around the world. You can see on that map there. And the hope is, and side by side, we also have a program on biomanufacturing workforce training with a hub in South Korea, and regulatory system strengthening, without which, of course, you cannot produce safe and effective health products for the population. And many countries do not meet the WHO regulatory benchmarks as yet. So there's a lot of work to be done across all of these. But the idea is that this network of hub and spokes becomes a very vibrant R&D community that uses mRNA, not just to make a COVID vaccine, which has been done already in South Africa. It will now go through clinical development, but also to produce other vaccines that are needed globally, and perhaps other products also, because mRNA does offer a lot of potential. Next slide, please. This just shows the kind of network of researchers we have. I mentioned the research roadmap that we had developed, the convenings that we have been doing. Next slide. And there's been tremendous interest in collaborating. The WHO R&D blueprint for epidemics was set up in 2016 after Ebola, and essentially laid out a list of priority pathogens and the work that needs to be undertaken for each one. And at the end, we had something called pathogen X, the unknown pathogen, which, of course, in this case turned out to be COVID. So this type of preparatory work is very helpful. And without that, we could not have really moved as fast as we did when COVID came along. Next slide. This is an example of a large platform trial. It was run by WHO, the Solidarity Trial. Canada was part of this. And we essentially had literally thousands of doctors who treat patients participating with a very simple digital way of participating in this trial. And today, we still continue with this trial, though, of course, severe disease has come down around the world, so enrollment is slow. It was looking at hospitalized patients, and it looked at a number of drugs, initially repurposed drugs, and most of them were found not to be very effective. And now we're looking at some anti-inflammatory drugs in the second phase of the trial. Next slide. So those are the kind of platform trials that can give you robust evidence and that also involve people and communities around the world. We also innovated on how we do our guidelines. Traditionally, they're updated, every few years, but we realize that when you have a fast-moving situation where things are changing, new data, new evidence is coming in on a regular basis, we decided we needed to update our COVID treatment guidelines, for example, every week or every month, or as often as needed. So we went into what we call the living approach, with regular updates to our systematic reviews and updates to the recommendations, either saying this drug is or not effective, and when and how and where it should be used, etc. This is something that we would like to now adopt across WHO for all disease areas. Next slide. And you can use artificial intelligence and so on to trigger when you want to update your guidelines. And this is just to show you, this is what the guideline looked like, but it was also available on a digital platform so that one could easily access it. Next slide, please. The last version of this actually addresses post-COVID and talks about, the kind of rehabilitation that's needed. On the digital side, I think there was huge expansion of the use of, digital tools and technologies. And again, I think this is where we have still a lot of potential to learn and to use some of this in our regular day-to-day practice of healthcare to basically make it easier both for healthcare workers and for patients to get good quality care and to be able to keep in touch and to improve the efficiency of the program. So again, these tools have to be used, in obviously with the health workforce and cannot replace people, which often sometimes I think policymakers believe that you can replace humans with the apps or technologies, but that's not the case. Next slide, please. Again, an example of countries wanting to have interoperable standards. COVID vaccination certificates, they asked WHO to produce open source standards, which we did, so that they could work across borders. Now it's possible that we can move further with this and have electronic health records also, which are interoperable and which, there are some sort of global standards that get adopted. Next slide. We had, as part of our research networks, a very good bioethics working group. They came up with a number of papers and sort of very thoughtful pieces, policy relevant pieces during the pandemic, not really telling people what to do, but really raising issues around things like mandatory vaccination or the use of contact tracing apps or the use of human challenge studies and so on. So I think we should never forget that it's equally important, even during a pandemic, or more important during an emergency, to ensure that the ethical concerns and ethical issues are well considered when you roll out a new policy. Next slide, please. So as I come towards the end of my talk, I wanted to think a little bit about the future, both in terms of preparing for a global pandemic in a way in which we have a more fair and equitable response to the to a potential pandemic if it occurs, and there are some recommendations here that are around, under governance, under financing, and under systems. And under governance, of course, we have the central role of the WHO, which needs to have probably more powers and be stronger and better financed. But also that countries need to put in place, governance within their own national boundaries to check if they have their core capacities in place and, to have a system that can step up. At the same time, the financing, good news is that the financial fund that was proposed for pandemic preparedness has been set up by the G20 and will start dispersing funds to countries for preparedness. And we, of course, also need countries to invest, domestically in their own preparedness and surveillance systems. And then you need some global systems and tools and partnerships that need to be created. A countermeasures platform is something that's being discussed based on, the COVAX and the ACT accelerator sort of model that could serve for the future, learning the lessons and, trying to develop better models. Thank you. Next slide. Next slide, please. So this basically talks about the 5 C's that are going to be needed, starting from surveillance. We talk about collaborative surveillance because people need to share data, again, nationally as well as globally. There's a newly established hub in Berlin in order to advance this work. You have the access to countermeasures that we talked about, the community preparedness elements, which are extremely important, which were neglected in many countries. Communities really need to be part of obviously to be part of the response, and this needs to be built over a period of time. Clinical care, we saw the lack of oxygen, unnecessary lives were lost because oxygen was not available. This is basically what the pandemic did, was it exacerbated the existing inequities. So we knew that oxygen was lacking in many places, but it just became very obvious. So we need to make sure that, all those things are in place. And then the coordination function, which at the global level is WHO, but at the national level, again, you need a sort of a multi-sectoral coordination mechanism. Next slide. It's important that we build and invest and strengthen primary healthcare, because ultimately that's the front door of the health system. That is where 90% of a person's health needs can be met. And it's estimated that just by scaling up PHC interventions in low middle income countries, you could save 60 million lives, in the next decade, and increase life expectancy significantly. Of course, now we've seen a reduction in life expectancy because of the pandemic in many countries. And so we again have a lot of catching up to do. Next slide. So as countries are increasing investments in health, it would be wise to put most of it, in primary healthcare, in these three interrelated and synergistic components, including comprehensive and integrated health services, multi-sectoral policies. So for example, I showed you the risk factors at the beginning, which are things like air pollution and high salt, high sugar, high fat diets, or unhealthy diets. In some cases, it's water sanitation. So those things need to be addressed. Road safety, road accidents are increasing killers in developing countries. So you need action in other sectors other than health. And then, of course, the third principle would be the empowering and engaging of communities and increase social participation. Next slide. And so, as we recover from this pandemic, we're just coming out of the COP that was held in Egypt, which has been trying to make advances. Climate. So climate, the health of the climate or the health of the planet and human health are definitely very closely interlinked. We can't think of one without the other. And I'm just thinking of what our elder was saying earlier. I mean, they had such a good understanding of how to live in harmony with nature. Unfortunately, that's been lost over the last few generations, or rather it's accelerated in the last 50 or 60 years. And so we really need to, think about how we can also decarbonize our health system. Since we work within the health sector, there's now a big global consortium that's trying to decarbonize health, put renewable energy instead of many countries. There are diesel generators that power our health centers. There are many centers without running water. We talk about sanitation. So we're still far away from providing those very basic services. Air pollution is one of the biggest killers, and we can reduce, up to 7 million deaths a year if we deal with air pollution. 90% of the world's population, by the way, is breathing air, which is not within the WHO standards. Food systems, another very important area. We've got into ultra processed foods, and we really need to go back to eating healthier, eating whole grains, more plant-based diets, local, and also making sure that our farmers are get the right incentives for growing crops that benefit both our climate friendly, climate resilient like millets, but also nutritionally rich. Well-being societies, we need to really start thinking about well-being, not just about treating disease. And green spaces, for example, in urban areas are very important for mental health. Healthier mobility is again a win-win. If you can have better public transport, more cycle and pedestrian lanes and less cars, it helps people keep fit and also reduces emissions. And then, of course, a very difficult challenge of tackling commercial determinants. We have to work with the private sector, but we also have to have behavior change to make people actually have make healthier choices, whether it's in schools and school meals, or whether it's in the supermarkets. And this is a big area for work. What I haven't spoken about is the infodemic, which is the availability of knowledge, and a lot of it through social media. A lot of it is not credible information. It's rather misinformation or disinformation. And there's a growing movement and well-funded movements to seed these type of disinformation and anti-science, anti-vaccine type of messaging to confuse people. And unfortunately, this seems to be a worsening trend. And as scientists and as medical professionals or public health professionals, we have to think about ways to deal with the infodemic, to provide credible information to the public in ways in which they can easily understand, and to communicate with them, not just tell them. It's not a one-way. Very often, that's why we fail, is because we do one-way communication rather than having a dialogue with what people really want to know, what they're concerned about. And I'm sure that young people today are well aware, of the amount of time that people spend on devices, on social media, and it's going to be a whole new discipline, I think. But governments are going to have to grapple with it, because it's already having impacts on vaccination rates, for example, and it could well impact the acceptance of other public health measures. So with that, my last slide is just to thank you all very much for this opportunity, and of course I'm happy to stay on and have some discussion. Thank you.
Thank you, Dr. Swaminathan. There will be a brief opportunity for questions from our in-person audience, led by our own Dr. Stephanie Montesanti, an associate professor in the School of Public Health. Dr. Montesanti's research examines determinants of policies and systems change in addressing health of populations, with a particular focus on groups that are been traditionally experiencing vulnerabilities that has been quite amplified through the pandemic. Much like Dr. Swaminathan, Dr. Montesanti's work works from a deep understanding of the need to collaborate respectfully with community partners in order to design the appropriate equity-seeking policy solutions. And the wins will come in partnership to make those transformations happen. So with that, let me invite Dr. Montesanti to come and share a little bit about her research and also to moderate the panel.
Good afternoon, everyone. Thank you, Dean Johnson, for the introduction. It's really a pleasure to be here. I did want to thank Elder Oj for the opening prayer and blessing this morning and this afternoon, and setting us on it in a good way for the conversations, discussions we'll be having this afternoon. And of course, thank you to Dr. Swaminathan for her excellent talk in providing a global perspective on important policy priority issues that many faculty members here in the School of Public Health are addressing at a local level. And so here at the School of Public Health, many faculty members, actually I would say all faculty members, are really responding to global health priorities and issues and addressing equities and building equities within their own research programs. And one area in particular in the school where we are building equities collectively is in the area of Indigenous health. So Indigenous and Northern health is a key research area within the School of Public Health. And to the extent of how we've been really supporting from a strategic perspective to Elder Oj co-chairs an Indigenous health working group called Mamawe Atawaskoan. So truly led by his guidance and wisdom. And what we've seen across the country is a lot of changes in research, academia, and the policy landscape where we are addressing and building equities. And equity speaks more than just what we look at as researchers in terms of understanding health outcomes specific to population groups, be they Indigenous populations and communities, refugee populations or other excluded, underserved populations, but it also speaks to how we as researchers conduct our research. It speaks to how we work in teams, how we communicate, how we engage communities and build equitable partnerships, and how, most importantly, those relationships are fostered by trust. And that's so important in doing equity-focused health research. In Canada in 2015, the TRC, the Truth and Reconciliation Commission, calls to action were implemented. And the TRC calls to action envision how health equity might be achieved through transforming health services to be better equipped to address the specific social and political contexts driving health inequities. Dr. Swaminathan had really highlighted the importance of understanding social and structural vulnerabilities that impact health, and in particular, how we've seen how many inequities in health have been exacerbated or compounded as a result of the pandemic. And the pandemic also brought forward a number of areas where we've seen inequities unfold in new areas that have not been given a lot of attention, particularly in the area of digital inequities, or this concept that has been coined the digital divide. And as health services were moving online and the connecting with health and social service providers virtually had brought forth a number of concerns around how different population groups were able to connect in that virtual space or virtual environment. So really equity is looking at issues of access and inclusion. And needed system transformations include eliminating healthcare resource disparities, ensuring culturally safe services are free of racism, building provider capacity to effectively support healing by addressing impacts from multi-generational adverse life experiences, and engaging Indigenous and other excluded population groups so that their voices are heard and considered in the policies that are implemented and the system transformations that are needed. We also heard Dr. Swaminathan talk a lot about upstream innovations, and upstream innovations require that high quality and culturally resonant services inform structural and policy changes to ensure that healthcare is responsive to diverse population and community needs and priorities. The other point that I wanted to highlight, what I think is so important, not only to the work we do, but also in terms of how we tell our stories. And as we've heard when we think about equity, we often think about the gap, the health gap between population groups, including outcomes specific to access care or how care is experienced by diverse patient or population groups. But stories of deficits have been told many times. And in the work I do with Indigenous communities, this is something that is told over and over again, is that those stories of deficits have been told about Indigenous peoples within a Western or biomedical lens, and may reinforce inaccurate stereotypes and problematize communities while neglecting to explore what the root causes of health disparities are. And in fact, Indigenous peoples have responded to historic colonial processes with deep reserves of wisdom over many generations and possess a wealth of diverse and enduring healing traditions for promoting well-being. And I think that's so important for us to be reminded of. So it's time for us to reset the narrative by showcasing those stories of leadership, strength, and resilience, and the deep knowledge and commitments that communities hold to create new opportunities for the next generations. I also wanted to just comment about where we're seeing a lot of shifts happen in the research, academia, and policy environments here in Canada. The Canadian Institutes for Health Research, which is a main funder in our country for health research, have really shifted in supporting research to address health equity. And the Institute for Indigenous Peoples' Health, and this goes to Dr. Swaminathan's point about where research dollars are allocated to and where we're investing in research. And in shifting that narrative, we're really actively paying attention to in supporting Indigenous health organizations, Indigenous health leaders to be leading that research and conducting that work. And that speaks to where those funding dollars go. And so I think just with that, I just wanted to close my comments. I know I've had, I was given only about 5 minutes, but I think some of the important takeaways is really with respects to how we carry out and conduct research to build equities, ensuring that our work is truly community engaged and centered and building strong, trusting, equitable relationships. And why that's so important is because we come together to these tables with diverse perspectives, diverse ways of knowing and understanding, and we can't do health equity research without having that mutual beneficial relationship and understanding, and creating equitable spaces that no one owns, but spaces where each person's perspectives, values, priorities are understood and acknowledged. So with that, I want to thank the school for the opportunity to provide a few comments. Again, to thank Dr. Swaminathan for her excellent talk, and I will be facilitating the Q&A. So I think, Jackie, can I just go ahead and move right into that? Okay, so I think with that, we'll open it up for any questions for Dr. Soumya.
Please raise your hand and we'll come over with the microphones, the whole room here.
Do I take this one? Do I take this one? Oh, sorry.
Oh, isn't that nice? I was really intrigued by the slide on ethics. And I was wondering if you could say any more about some of the ethical questions, challenges that came to the WHO that you had to manage, think through, speak to, because I think a lot of that comes to our questions about trust and information and trusting information, trust who's credible in our lives, who do we think holds credibility. But the ethics slide was one that really intrigued me, and I'd love you to say more if you can. Thank you.
Yes, thank you for that question. In fact, you know, when we had this Research and Global Innovation and Research Forum in February of 2020, where we brought together in Geneva, actually, about 400 scientists, researchers from around the world. Even at that moment, when we set up our working groups, we had 9 or 10 different working groups on different topics. One of them was around ethics. And at the very beginning, we started looking at what could be the different topics, or they started looking at the different topics and issues that were coming up. I think contact tracing apps, for example, you know, many countries started thinking about using that quite early on, because contact tracing was an essential part of the COVID management, the public health policy. And of course, it does, you know, have implications for privacy and confidentiality, but also the fact that if they wanted to, the government could use that data for other purposes as well. And so there was a paper that they produced around the ethics of contact tracing apps and how the data should be used and managed, and what the public should be told. You know, things like the data should be destroyed after a certain amount of time, and it should not be made available, you know, to any other arms of government for other kinds of users and so on. Similarly, when we were thinking about vaccine trials, there was obviously thinking around human challenge studies, because they can speed up considerably vaccine development. But at the same time, the ethical issue there was that we didn't have a good treatment for COVID at that point in time. And so even if you took a group of people who were at low risk, like, you know, young, healthy adults, there was still a chance that some of them might get severe illness, and then how would you treat them? And so there was a whole framework laid out of, if you wanted to do a human challenge studies, how would you do by minimizing the risk? Another example was around mandatory vaccination. Of course, once vaccines were available, some countries were considering making it mandatory for either some groups in the population, or, you know, in some cases, everybody. And so our ethics working group actually looked at, you know, the pros and cons of having a policy like that. the considerations that a government should have if they indeed were to opt for it, like what would be the kind of, again, perhaps circumstances, maybe specific groups of individuals, for a certain period of time. Like some countries do have mandatory childhood vaccination for school entry. So again, it's a public health benefit versus an individual issue. And so they were all, very thoughtful. And again, one of the important early ones was around how would you distribute vaccines in the initial phase when we knew that the volumes produced would be limited and that people around the world would want access to it. So by that time, we knew very early in the pandemic, we knew that the older you are, the more vulnerable. And so it was clear that older age groups should be prioritized. It was also clear that health workers and frontline workers who were at very high risk of getting the infection should be prioritized. And so the WHO's equitable allocation framework that we came up with well before any vaccine was licensed, said, well, these are the high-risk groups. And so we believe that any vaccine that's available globally, whatever the volume is, should be made available to countries around the world for these populations, that would be the most equitable way of dealing with that scarce supply situation. And then as supplies increase, you can go to reducing age groups, decreasing age groups, and then other, adolescents and children would come last. Unfortunately, as I mentioned, that's not how it played out. If we had followed the WHO's allocation framework, the models show that you could have saved about at least 1 million lives in 2021 alone. But because high-income countries had most access and low-income countries had to wait a longer time, the framework was used basically to allocate doses which came to COVAX, but that was only a small part of what was being available globally. So those are a few examples, but there were many others, and they're all available, these papers, on our website, and they're very interesting reading.
Yes, Susan has.
Hi, I'm Susan Chatwood, and I'm a professor here at the School of Public Health. Thank you for your talk. And my question is around the slide with the global mortality distribution, the reported versus excess deaths. And as a health systems researcher, that's an interesting slide. And of course, we were hearing a lot of narratives around this during the pandemic. And I'm wondering, what you expect the trends to look like now over the years, because I think, we're still in a systems crisis, and what role some of the innovations that we've learned for, say, around e-health, or are there sort of solutions that we can take from the pandemic as well? The challenges that come out of it, but yeah, are there lessons learned within that?
Mm-hmm. Yeah, that's a great question. It's something that it's been a concern for me for a long time. On the excess deaths, I think we are countries that have good data systems, I think, can look at this. And certainly I've seen some of the data coming out of the UK that shows that the excess deaths today are higher than they have been at any time over the last 5 or 10 years. And these are people who are COVID negative at the time of death. So why are there excess deaths? Now we know also that once you've had COVID, you have a higher risk, a 2 to 3-fold higher risk of developing cardiovascular disease or stroke or diabetes in the year following that infection. And the more infections you have, it appears that the higher the risk. So COVID is doing something to many of our body systems, cardiovascular, neurological, vascular. We don't understand fully exactly the pathogenesis of this post-COVID. But that could be, but it could also be the lack of medical services during the pandemic, and people perhaps didn't get attention for their cancer or whatever, and that may be leading to excess mortality. So I think we should track this globally to see if I mentioned the reduced life expectancy across the world. But I think in terms of opportunities, I've been thinking about this poor death reporting in many countries, and why can we not use the kind of mobile messaging systems or apps that we used to collect data and transmit in messaging during the pandemic to actually collect death data more holistically. It's really important for countries to have that information, and many high-income countries have it and use it, but it's not available in the developing world. But also, I think telehealth can help to bridge the gap, though, of course, as the previous speaker said, we have to be very cautious about digital exclusion and the fact that the same communities may be left out of physical health services as well as digital health services. So, but if we're very conscious about it, then I do think that a nurse in a remote community could benefit a lot from having a telehealth consultation possible, or even group consultations. You know, we did a lot of sessions during the pandemic using the ECHO platform that was basically meant to train healthcare providers who had never seen such syndromes or having to use oxygen in remote settings. They had never used an oxygen concentrator or different devices. And so we had these online sessions which were learning sessions for doctors and nurses, who were able to talk to experts. And it was a case-based approach of mentoring and learning. And this went on through several months of 2021. And I remember attending sessions in Nepal, for example, all online, where 700 doctors would gather every Saturday evening to discuss real cases they had seen with experts, you know, from the Mayo Clinic, who were experts in intensive care or respiratory management. I think that sort of platform is for us now easy to imagine. The way we're doing this meeting today, we could be mentoring and training healthcare providers and even community volunteers in remote communities to improve their health. I think we need more research, more health research on the effectiveness of digital technologies in terms of how much value they add in improving health outcomes.
Thank you, Dr. Swaminathan. Dr. Swaminathan and Dr. Stephanie Montesanti have given us a lot to think about in terms of the deep and wide impacts from the pandemic, the lessons learned, and the lessons we will continue to learn, and the influence we need to have into the community. So I want to thank every one of you for joining us today for the 2022 Douglas R. Wilson Lecture. I especially like to thank everyone who had a hand in organizing this. The tremendous amount of work happens behind the scenes. So wanted to thank Jackie and the team from the School of Public Health, and also from Alumni Relations and the University of Alberta team for helping us, making it a big success. And of course, I'd like to thank my sincere gratitude to Dr. Elder Auger and Dr. Doug Wilson, and your prayers and blessings and commitment to public health matters so much to us. And again, Dr. Swaminathan is extremely busy, and she accepted our invitation to share such tremendous data and experiences we've had through the pandemic. And so the information would be useful for our students, for our all across our spectrum of public health people who are gathered today. I want to invite you all to spread the word about the work we are doing at the School of Public Health, including today's lecture. A recording of the event will be posted on our website of webinars for alumni called On Demand, which is accessible. I have often gone in and listened to other lectures I could not participate, so it's fairly easy to access, and please feel free to listen again, pass it on to people who might be interested. And lastly, I invite you all to continue to invest in public health by giving your time at events like this one, by sharing your skills and expertise through the work in our communities. There are so many preceptors that support the learning of our students through their practicum opportunities. Sincere gratitude to the preceptors and partners, and also through continuing to help fund and support our research and teaching. And today's announcement, again, it was so remarkable by Dr. Wilson that it supports our future generation of public health experts. I especially encourage your support for our Northern and Indigenous Excellence Project, which is outlined on our website and in the email that you will receive after this event. Together, we can all contribute to the foundations of a healthier future for all global citizens, amplified and exacerbated through the pandemic, but we can make a difference. Miracles do happen, and we need to be able to work together to achieve the outcomes that we want to see. Thank you all for joining, and stay on and mingle. And again, a round of applause for our guest, Dr. Swaminathan.
Thank you. Thank you very much.
Mm.